Want to welcome everyone to our weekly conference. Most of you are regular attendees, which is good. But some of our conferences we designate as IDL talks, and I think most of you know IDL stands for the Informatics Discovery Lab, which is this initiative in the department to try to branch out, expand our horizons a little bit in the form of collaborations with industry and other, shall we say, non-traditional, at least for us, partners. And so this is the first IDL talk of the academic year. And we happen to have a speaker who's a local entrepreneur. And one of the other goals of the IDL is to promote local interactions with industry for the benefit of all. So our speaker today is Dr. Ray Costantini, who's a physician, and he is recently left his prior job at Providence Health and Services, where he was medical director and director of their digital product strategy. Now he has gone off into the wild yonder of startup companies, and he's going to tell us about his work with his company, Bright.MD. Just by background, he received his bachelor's degree and MD from the University of Arizona, and he also has an MBA from the Thunderbird School of International Business. So.
Fantastic. Well, I'm thrilled to have so many people here. I was just telling Aaron, I was kind of hoping there'd be like 2 of you, and I wouldn't have any pressure on me, but we'll see what we can do to make this work. I also heard that I have a captive audience and that some of you guys have to be there because this is classwork, which is awesome. I love it. That makes it that much less pressure for me, too. I definitely remember getting lectures from folks, and I would rather have this not be a lecture and have it be interactive. If you guys have questions, I would much rather know what you guys want to hear about and talk to that than stand up here and try and guess and do that. I definitely have some stuff I'll go through to kind of set the stage, but jump right in, throw up your hands, or a tweet, I think is how we're getting questions from folks from elsewhere. Yeah, so please make my job easier and ask me lots of questions. That'd be fantastic. But as Bill said, I am Ray Costantini. I'm a physician. I am now a 4-time entrepreneur. I've done this a couple of times, which means that I am certifiably nuts. And we'll talk about more about that and entrepreneurship a little bit later. But the first thing I thought that might be helpful, the idea of this talk was to talk about transforming healthcare and how entrepreneurship can play a role in that. And in order to talk about that, the first thing I thought would be worthwhile would be to talk about healthcare itself. And I actually had a really interesting conversation with Bhumi before the lecture today, and we were talking about defining things and how important it is in order to be able to change something. They say you have to be able to measure it, and I think that's very real. If you can't measure something, you can't change it. And even if you are changing it, you don't know whether you have. But in order to be able to do that, first you have to be able to define it. And for a long time in healthcare, I think we were without that compass in terms of what is it that we're really striving for. We would look at pieces of it, which are incredibly important as well, and we would make progress in each of those directions. But more recently, there's been, I think, personally, a really fantastic compass, which is that triple aim. And I think about this slightly differently than I've seen other people talk about it. It's probably my quantitative brain. I think about it as a formula. You think about outcomes, and you think about experience, and you think about per capita costs, which I think probably all of you guys have heard about in terms of triple aim. Anybody who has not heard about triple aim in terms of value? Perfect. Yeah, raise your hands. That's totally okay. That's why I'm asking. So this is actually, so the IHI was really the place where this kind of developed, and it's really a fantastic way to think about it. And to be honest, this doesn't just apply to healthcare. It's just funny because it's applied to lots of other industries, all other industries, but healthcare didn't really sink its teeth into it and think about it themselves that same way. So the idea here is, in order to meet that triple aim, in order to be able to make healthcare better, we want to improve outcomes, and we want to improve experience, and we want to drive down cost. And I mean, that's pretty sensible. You do that in almost any other industry as well. The interesting thing to think about, though, is that it really is a ratio. And what you're trying to do is maximize that ratio. You want to make it as big of a number, if you plug those numbers in somehow, as possible. So if you raised quality outcomes, that first piece, through the roof, just crazy, fantastic outcomes, but you raised per capita costs at an equal amount, you haven't optimized that ratio. It's really about being able to create those things in relationship to each other. And so with that in mind, and defining that, again, as what healthcare value looks like, as a starting point, we could have whole conversations about that as well. Let's go through some of those pieces, particularly for the U.S. healthcare system. So we spend the most. We're going to start with the denominator here. I mean, by far and away, the United States spends more than any other country in the world, and this is on a per capita basis. Now, if you turn this from a per capita basis into total spend, the United States spends 2 to 3 times more than any other developed country in the world on our health care. So you can see that. We're number one. We're really good at that. We spend a ton of money on health care. Now, our quality rankings. So the WHO went through and did quality rankings on healthcare systems across the world. I did a ton of countries. And number one was France. They did a fantastic job. Great score, 994. Japan, UK, all of them have fantastic systems. Now, you notice the United States is not in those top 3. In fact, it is number 38th in the world. It is below every other developed country in the world. In fact, it's below Dominica and just above Slovenia, who incidentally spend a tiny, tiny fraction of the amount of money that we do on healthcare. Now, to put this into a business context, we're getting a really crappy return on our investment. We're putting in a ton of money, and we're not getting outcomes on the outside to show that. We're not getting experience. Well, that's another piece. Let's talk about that. So we think about that ratio again. We just talked about spend. We just talked a little bit about quality, and they included a number of endpoint metrics in here, including longevity, maternal fetal mortality, quality of life, access to care. That was all included in that quality piece of it. But now about experience of care. And the truth of the matter is, nobody's getting a great experience of care in the United States either. It's not like we have kind of mediocre quality, we're spending a ton of money, but the experience is just extraordinary. That's not really true. And we tell ourselves that sometimes. We talk about, oh, well, those Canadians, they wait forever for health care. Guess what? This is the United States. This is primary care access right now. It's terrible. In fact, it's true, Canada is worse than we are, but they are the only developed country in the world who has worse primary care access than the United States does. And in fact, they're getting better. We're getting worse. That is not a good trend line there. And you can see, this is miserable. I mean, the best is days that you're waiting, and that's like one major metropolitan area. You're talking about weeks to months. Look at Boston over there, 66 days to be able to get primary care access. That's miserable. I mean, that's really not, and we're spending a ton of money to be able to do that. And the question then is why? And here's a big part of the reason why for that particular setting. So now we're kind of trying to drill in a little bit around one particular subset of care. We'll talk about primary care for a few minutes. Why is primary care access so difficult? This is a big part of it. We have an exploding patient demand. We have an aging population. We have a growing population. We have new legislation that's pushing the really sick people who didn't used to get primary care. They've got this huge pent-up demand into the system now, and so they're consuming not only one more person's worth of healthcare services, but a pent-up demand of years of service. Incidentally, we are also the only country in the world, the only developed country in the world that does not still have universal healthcare coverage. So another issue around there around both experience and quality. And so we have started pushing more of those people into the system, and that's making it worse. And then we have this provider supply issue, where it takes years to train new primary care providers. And then you got to convince them to go into primary care, which is not an easy thing to be able to do either when you're coming in under a bunch of debt. And there are other places where you can make more money and have a better lifestyle. You really have to have kind of a passion for primary care to go into that. Now, the other thing is that even once you go into primary care, it's hard for docs too. We talk about that experience of care for patients, but what about the experience of care for providers as well? And this is something I had a lot of conversations with people about I don't want to imply that providers are the reason for healthcare. They are part of the, to put it in business terms, providers are part of the supply chain. They're an input into the overall healthcare delivery process. They're an incredibly important piece of that. But patients are our customers. They are the people who we are here to serve. That's what healthcare is for, is to make patients better. But the truth of the matter is we have to be thinking about this as well. And primary care is hard for docs as well. We're seeing declining margins. They're making less money. They're being asked to do much, much more for a lot less as well. You know, we started where, you know, not that long ago, you see 10, 12, 13 patients a day. Now, and 15, and then 17, and then 19, and then 20, and now 22. When we're hearing from delivery systems that they expect their primary care providers to get up to 25 patients per day or more, that's a lot of churn. You put them on a treadmill, and you turn up the speed, and you flog them a little bit if they don't go fast enough. And that's kind of the process we've gotten into. On top of that, you've got these new business models. You guys are probably familiar with the Affordable Care Act and some of the moves towards value-based care as compared to fee-for-service. Does that sound familiar to anybody? Anybody it doesn't sound familiar with? Everybody, you guys get the idea of moving to a kind of a capitated system? Okay, good. That's actually a huge piece. So understanding how that stuff works is a really important part of thinking about how is healthcare going to get reshaped. It's a really intrinsic part of the future of healthcare. So the question is, we've got this broken system where there's not a good experience, there's a ton of money getting spent, and quality is not matching with what we would expect given those inputs. Why is that? Well, oops, wrong button. You guys already saw that one. So what does it take to have a really efficient system? What makes any industry run smoothly? There's three things that you really need, and we could spend hours talking. This is economics. I mean, we could spend hours talking about this all in itself, but in the end, three big buckets of things that you need in order to be able to make any industry or system work really smoothly. One of them is competing suppliers. So you have to have multiple people saying, we want to provide a service, right? And then you need engaged customers who want that service and are interested in what makes one of these suppliers better or worse than another, whether that's price or quality or experience, or, you know, there's a ton of things that you can differentiate around, but that's really, you know, those are two really important pieces. But then in order to let those two folks interact, you need that third piece, which is transparency. So you've got customers who are interested in the things that these suppliers are competing to provide and provide better than each other, right? But you have to be able to know about those differences. We don't have any of those. Not one of those three things does healthcare have. And this is really interesting. I mean, you think about competing suppliers, we really don't. I mean, in a lot of markets, this is someplace you've got a single hospital and you've got a single insurer who makes up the vast majority of the market. So there isn't a lot of competition in that space. You have engaged customers? Well, sometimes. But I would say that's at best. You think about how much time somebody spends shopping for a car and researching whether you're going to buy a Prius or a Ford Focus. People put in a bunch of time around that. They don't put anywhere near that amount of time into researching which provider they go see or what should they do for their low back pain. And we could talk a whole bunch about why that is. It's not necessarily because consumers aren't interested. Maybe because they don't have that third piece as well, which is that transparency, the ability to be able to see those. Where would you go, even if you wanted to know about how much something cost or the quality of the services that you'd be getting? I mean, if you want to know about a Prius versus a Ford Focus, you go on Consumer Reports and you can do some research, you get that information, you can look at the cost, and you can shop around. You can't do that in healthcare. There aren't the resources available to make that happen. So that is really what we have, is we have a system where none of those pieces are there. They're all missing, and so what we have is a really rusted, inefficient system where it's difficult to make things better. There isn't that competition or that transparency or that engagement to drive that forward, and it's tough. But it also means that there's a lot of opportunity to make things better. And we'll get to that in a little bit when we talk about entrepreneurship also. But there's also this question about why else? Why, you know, we talked about the difference between value-based care versus fee-for-service, right? You guys are pretty involved in healthcare. How many of you guys see fee-for-service as just like, it's the wave of the future. You know, we are going to continue doing fee-for-service, and that's, anybody? Be brave. I mean, it's okay if you think it's a good conversation to have. I run into people sometimes who do, and it's totally all right. All right. Any tweets? Okay. So, not about that one. We all know that this is moving forward. We all know that we're going to shift from this model of do something, submit a bill, get paid, broken system. I mean, we could talk a bunch about why that system is broken as well. Talk about incentives and broken incentive systems. And, well, God, you know, what does that incent? If we've got a fee-for-service setting where I do something, I submit a bill, and I get reimbursement, period. And that largely encompasses what a fee-for-service is, with some nuances in there, but largely that's it. What does that incent? It incents filling hospital beds. That's what it incents. It makes hospitals and delivery systems, it makes them into a system that is rewarded for filling hospital beds rather than keeping people well. And that's really unfortunate. Unfortunately, we're in an industry that's full of people who want to do good. So despite the fact that we've got this broken incentive system, we still have a ton of people out there who really do want to do the right thing, and they'll do it in spite of the fact that they're being disincented around it. I mean, no good deed goes unpunished in a delivery system under a fee-for-service setting. You're a fantastic primary care provider, and you decide that you are going to hire more staff to help you better manage diabetes, your diabetic patients. And you go out and you find a diabetic educator and a social worker and a patient navigator, and you bring them into your practice and you pay them to do that, and you make all your patients better. You can't bill for it. You get really, I mean, for any of those pieces, if you bill for them, you're billing at a much lower rate, and you can't really make that, financially it doesn't work. And the other problem is, on top of that, now you've made your patients healthier, which means they're not coming back to see you. So not only are you spending more money, you're making less money too. I mean, that's terrible. I mean, that's really, really broken. And everybody knows this. And the question is, why aren't we changing? Why aren't we saying, okay, we know this is broken, and everybody knows it's broken, and we know where we're going. We see this future point. Why aren't we changing faster? I'm going to tell you guys a story. I have 4 kids, by the way, and I like to tell them stories. And this is one I like to tell. It's Cinderella. Now, you guys have all heard the story of Cinderella? I'm going to do a slightly modified version here. But really, in some ways, healthcare is really in a similar boat to Cinderella. You know, I mean, Cinderella goes to the ball, right? She knows that at midnight, it's going to hit the fan. She's got to get out of there, right? And what's she going to do? What's the first thing you do when you come into the room if you're Cinderella? You find a clock on the wall, right? You're like, I need to know what time it is. Because, you know, when it gets to be midnight, I got to be doing something a little bit differently. And that really is. It's the same thing as our U.S. healthcare system. But the problem is that there isn't a clock on the wall for the healthcare system to be looking at. You know, we argue about what time it is. You know, we know that at some point we're going to move to this fee-for-service environment, and that's when the clock strikes midnight, and everybody knows that they're going to have to get out of the party, right? But what time is it? Is it 11:55? Is it 9:30? You know, it's coming, and everybody knows the clock is ticking, but we don't really know what time it is, so we spend a bunch of time arguing about what time it is. The other difference is that, unlike Cinderella, so Cinderella, she knows come midnight, everybody else is going to keep doing their own thing, and she can kind of sneak out the back door, and it's not a big deal for her in the spectrum of things, right? The difference here is when the party ends, everybody's got to leave at the same time, and there's a mess, you know. And I think I'm skipping some of my slides here, so forgive me. I'm going to jump ahead on a couple of these. They're pretty pictures, but I think you guys are getting the story, anyways. We really don't. We have that broken clock, and for Cinderella, the problem here is not only for her she can get out, but for healthcare, not only do we not know what time it is, and not only do we realize everybody's got to leave. When the clock finally rings, what happens? It's not going to be some nice orderly exit where everybody files out of the ballroom. It's more like a fire at a rock concert, right? I mean, you think about this. All of a sudden, the bell's ringing, and everybody's like, oh, my God, everything's changing. We all know it's time to go. That's scary. And the thing that happens is that people get trampled. There are mortalities in that process. I mean, there are actually predictions out there that 30% of hospitals will be shuttered by 2025 because of this same thing. Because if we actually successfully move from a heads in beds business model of making money by having people who are sick get treated in hospitals to a model where we're incented to keep people well, that's a big change. And there have to be casualties in that process. The question is, who's going to successfully get out of the building, and who's going to get burned in the fire, and who's going to get trampled to death on the way out the door? It's a little messy. And so that's really the question. But so same thing. This all sounds scary. Like, well, God, why am I not standing by the door? And that's the real question. And the answer is, as we've been dancing around, you get this healthcare Cinderella dancing around the ball, she's developed a really big appetite. You think about all those hospitals, and there's a huge capital investment that's gone into those hospitals and those clinics and the delivery systems and the imaging equipment and the staff and everything that goes into that. And it's there, and it's hungry all the time. And as we're dancing around, we've got that appetite. And the thing is, as we start moving towards the door, imagine on one side of the ballroom, there's the exit, right? And on the other side of the ballroom, there's a cake table. And you're hungry, right? Which side of the ballroom do you want to be on? You know that at some point, the bell's going to ring, the fire's going, and you got to get out the door. But you're hungry still. And you think, we're good at eating cake. I mean, that's the truth of the matter is we're really good at eating cake. And when I step away from the door, when I step away from the table over there and I step towards the door, every step away that I take makes me hungrier because I can't get the cake. And that's a big part of what keeps us from moving forward around this and why we have these delivery systems. So I'll pause for a second here because I'm going to shift gears. That kind of paints an ugly picture of where we're at, and I don't want to be all doom and gloom, but I do want to pause for a second. There is a sunnier side to this whole thing, I promise. Any questions or thoughts at this point from you guys? I know I'm not that informative.
I think we all want to see what's next.
Well, fair enough. The next thing I was going to do is I was going to talk about entrepreneurship a little bit as well, because I do think that is truly, I mean, it's a messy space we're in, but the neat thing about entrepreneurship is, well, I had somebody tell me once, I tried to put together a good slide around this, and I couldn't think of a great way. I was told once that there is a Chinese character for adversity, and it is incredibly similar to the Chinese character for opportunity. I don't think that's actually true, the characters, but I do think that the sentiment behind it, everybody thinks the Chinese characters say everything. That's why people get those crazy tattoos that don't mean what they really meant them to say. But I mean, in the end, I think that really the concept behind that is very true. And it is a question of perception, of how are you framing this, how do you approach this. All of that we just talked about, it is a terrible adversity, which means that we're in an incredibly target-rich environment. You can swing a stick and help make healthcare better. I mean, that's awesome. That's so cool. And so with that, I'm going to transition a little bit into kind of how oh, yeah.
Before we get into entrepreneurship as the answer, what are your opinions of federal policy? Do we have the attention span to move from a fee-for-service system?
Yeah. So what role, you're saying what role does the federal government help in making that happen? Yeah. Yeah. I mean, I think so. I think large established organizations, established companies have a tremendous amount of inertia. And that's not in healthcare. That's just period. That's just the way that business works. I mean, businesses start as snowballs as an entrepreneur. Every business starts as an entrepreneurial venture. Every single one of them. And they start as these nimble little snowballs that can adjust and move around in their environment. And they start to build inertia, and they just keep moving in the same direction. And eventually, they kind of become glaciers. And that's not necessarily a bad thing either. In a stable environment, where the landscape is pretty steady, glaciers carve continents. They're incredibly powerful and useful to be able to do that. There's a lot of power in that inertia. But once the environment starts changing, that's tough. Now, the federal government, they can help with those things, and I think we're seeing some of those pieces, they're incredibly motivated. That's the interesting thing. 20% of GDP, almost 20% now, and it will be 20% very shortly, gets spent on healthcare. If we don't fix that, and on top of that, hold on, not just 20% of GDP gets spent on healthcare, which is more than any other industry, substantially more than any other industry or piece of spend in the United States. There's nothing that even comes close to touching that. And it's growing at twice the rate of inflation. So you're spending way more, and the rate of spend is increasing exponentially. That's scary. Think Greece. And that's what policymakers in the federal government are thinking about right now, is that we will be crushed under the cost of our health care as a company. We will be Greece if we can't fix that. Now, the challenge on the federal side is they do it in short stretches. And their job, and I'm going to be a little they need to make sure that whatever they've done works in the 4-year span that it takes for them to get reelected rather than over the longer term. So I think that there's a balancing act. I don't think that they're the answer, but I think that they're an important component. Is that fair? Okay, perfect. So entrepreneurship. My wife likes to tease with me. I think she's teasing. And she asked me, what's the difference between being an entrepreneur and being unemployed? That's the end of the joke. That's the whole thing. No, she is generally kidding when she says that. There's definitely a difference. And it's tough. I mean, I can't lie to you. I will not paint you an overly sunny picture of entrepreneurship. It's very exciting. There are a bunch of reasons that I can tell you why to go into it. How many people here have started a business? Oh, good. Okay, we get some hands. Okay. No, that's good.
Depends on what you define as a business. Many people would consider this department a business.
You know what? I think it's a great point. And actually, when I was at Providence, we started a department. We called it Intrapreneurship. And it is different, but there are a tremendous amount of similarities. And bringing some of the same entrepreneurial skills and mindsets to bear in these large established organizations can be a huge challenge. You know, try spinning snowballs off of a glacier. It takes work, and it's a very, very powerful thing to be able to do as well. So I agree completely. So I'm going to give you a couple of don'ts first. Don't become an entrepreneur because you don't want to have a boss. Bad idea, because it doesn't work that way. I should have asked, are there any investors in the room? No, I'm teasing here. I will say honestly, investors can be a fantastic partner as well. But the truth of the matter is, and I say this in jest, but you don't get away with not having a boss anywhere. When you form a company, you are serving the needs of others. If you want to have a successful business, that's what your job is. And if you don't have a board and you don't have investors, you've got clients. They're your boss in the end. And I think that that's a really important thing to me. Don't go into entrepreneurship because of that. Well, what is entrepreneurship? What is the difference between being unemployed and being an entrepreneur? Part of it is an endless curiosity. Being really interested in exploring and wanting to explore. And that's a huge piece of it. Entrepreneurs are good at that. They ask questions. And even more importantly than asking the questions is they listen. And that's really important. But on top of that, and I think who was I? Faiza. I think we were talking about this. It's not just listening, though. Entrepreneurs also, you need to be able to take that information in, and you need to be able to process it. You have to really think about it. If you just take whatever information is thrown at you, you guys are in the informatics program. You guys know the difference between data and information. Yeah? I mean, data is just data. I mean, it's bits and bytes. It's just stuff that kind of gets flung at you. Information is something usable, something that you can actually do something with. And you have to convert this huge flood of data that you can get from everybody out there that you're working with into usable information. And that requires a lot of thought process as well. And then even more importantly, the other thing is you have to be motivated and you have to take action. And you're going to have to do it when you don't have enough information. it's one of the scariest things about being an entrepreneur. And raise your hands again. Who'd started a business? Yeah. So, I mean, when's the last time you had all the information? You're in a business of your own, and you had all the information you wanted to make a decision. I don't know if I can remember the last time that happened for me. I mean, and you get more information in larger organizations, which is great also. As an entrepreneur, I think even more so. You have to be willing to take those actions and then adjust as well. You have to be constantly coming back to that same full cycle. That whole thing is iterative that we just went through. After you've taken that action, then you need to be curious, and you need to really open-mindedly look and understand what it is that, how did that impact? Was it right? You form a hypothesis, you execute on that, you test it, and you have to listen and understand that. You have to be curious, you have to listen, you have to think, you have to act. And you keep doing that cycle over and over again, and they're pretty small circles. You have to be iterating pretty quickly around that. Another reason not to be an entrepreneur, really quickly, is the money. Don't do it for that reason. Now, that doesn't... Oh, shoot. It skipped forward on me there. I was going to talk about this. 48% actually of GDP is actually generated through small businesses, 20 employees or smaller. So there's a huge impact that entrepreneurs also can have in that process. Another perspective around this is job creation. 63% of new jobs in the last 15 years were created through entrepreneurship. And then another one, 89%. 89% of total employment is across the country, not new jobs, but total employment is actually in companies 20 or smaller. So, there's a huge impact that you can have through that entire process. And I kind of suggested this earlier, but 100% of jobs ever created were started by entrepreneurs. Every single company out there, somebody had to be entrepreneurial. Somebody had to say, I have this cool idea for GE or IBM, and I'm going to make GE or IBM or Epic or Bright.MD or whatever it is that you're creating. Every single job out there, whether they're doing it for themselves or whether they're doing it as a company and employing other people, it's hugely important and impactful. The last couple things I'll say about entrepreneurship is that you also, all of those things are really good, and they're good reasons to be an entrepreneur and the impact that you can have. You also really do have to be an optimist. And I don't mean to be overly sunny. I generally think of myself as a bit of a pragmatist, which is not the opposite by any means of an optimist. But optimism is really important. And you're going to have a ton of people, if you're in an entrepreneurial environment, tell you, this isn't going to work. You really ought to go do something else. And this is going to fail. And the thing is, you have to maintain optimism through that process. But the sad thing is, they're right. They're right when they say that. 80% of new companies fail in the first 18 months. And that's part of that same iteration process. And you kind of have to be okay with it, or at least not pay attention to it. If poker is a good analogy for entrepreneurship, actually. I don't know how many people play poker in here. We got a couple people. Okay, so there's two ways you can see people play poker, and we could talk about which one's more successful. You can play each hand, and you can try and win the most hands possible, right? Generally not a particularly successful strategy at poker. Or you can play a lot of hands, but play them really small, and wait for a winning hand, and then play that winning hand really big. And I would encourage anybody who is interested in entrepreneurship to take that second approach to their business processes as well as their poker playing. Does that make sense? You're going to fail. I mean, there will be failures in that process. The question, I tell everybody, I don't mind failing. I just don't like repeating the same mistakes twice. And I think that's a really good thing to be able to take away from it. So that's entrepreneurship as a whole. I could tell you guys a little bit about me, although I hate talking about myself. I probably ought to fit that in there someplace. I think, Faiza, you'd asked me to do this, so I will be nice, and I will do that. So my background, I am a physician by training and by practice, although I would say that I'm an entrepreneur at heart. I started my first business at 17 because I really didn't know what else to do. I actually kind of fell into it, and I had an opportunity to be able to do something that worked out nicely. I actually did real estate investment and development, which is very different than healthcare. And if you guys are interested in real estate investment and development, you can ping me sometime, and I will tell you about why I left. But it largely has to do with the same thing I was mentioning earlier. People are in healthcare because they want to do good. They want to make things better in spite of incentives. Generally, and I won't say this about everybody. There's always a bell curve in any space. But in real estate, folks are in it because they want to make a bunch of money. And that's all right. But I really did want to be in something different. And so I had that opportunity to be able to look around and see what was out there and really realize that healthcare was it was the right space for me to be in. It was a calling, more of a vocation. And so I went to med school and came up here for residency. And in the process of seeing patients, I was realizing a couple of things. One, I missed entrepreneurship. It's a different kind of thinking. How many clinicians do we have in the room? All right, cool. We got clinicians too. That's good. I think I personally really, there are pieces, I don't practice, and there are pieces of clinical practice that I miss. I miss, being able to walk into a room and instantly develop a rapport with a patient and, ask them anything. You can ask them, how many times can you walk in a room and ask somebody to take off their underwear and tell you about their drug habits, and they do it? And thank you for it. I mean, and you actually did them good in the process. That's really neat, exciting stuff. But I kind of realized that a lot of the patients that I saw, they were sick, in part because of the same issues that we saw at the beginning of the presentation. The system was broken. They can't get access to care. We're 38th in the world. We're at the bottom of the pile of developed nations in terms of our ability to be able to effectively deliver care to people. And I wanted to do something with that combination of skills, with my clinical expertise and my business experience and my ability to be able to think about things that way, that they could have that broader impact and be able to make things better, not one patient at a time, but kind of across a system. And so there's a funny thing that happens when you get an MD. Your clinical credibility goes way up. That's probably not surprising. Interestingly enough, and unfortunately for many situations, your business credibility tends to go down. And that's unfortunate, but true. So I'd go back and get my MBA to kind of let people know that I actually can think about things from a business perspective. And then worked at Providence for about 5 years. I did some consulting work in there too, but worked at Providence for about 5 years. Was medical director and helped lead product strategy. And that's a funny word in healthcare. What do you guys know? Anybody familiar with product strategy? That's a limited number of hands, but that's good. I'm glad we got at least one up. That's good. In a very nutshell version, and again, if you guys are interested, I think it's huge. If you can bring a product mindset to whatever it is that you do, I think it's a really powerful thing, and not only in entrepreneurship, anywhere. How am I solving people's problems? I mean, that's a very limited function of that. I mean, like I said, you could talk a bunch about what a product mindset is, but really, what is the problem people are trying to solve, and how can I best do that? It's kind of a tenet that you could build product around. That was kind of what I did for Providence. I thought about clinical strategies. How do we bundle care services in a way that better meets people's needs, helps them actually solve their problem? Nobody actually wants a hip replacement. What they want is to not have hip pain. That's kind of the problem that you're trying to solve. And so how can we better meet that need? How do we build digital products to help people understand their options, shared decision-making tools, and portal tools, help them understand cost, and solve some of those same problems that we were seeing at the beginning of this of the presentation as well. So how do we build those? How do we bundle things differently? And that was interesting and very exciting. And but eventually, at some point, I realized that I did really want to get back to entrepreneurship and do snowballs instead of glaciers. So that's kind of the short version on me, well, kind of the mid-sized version on me. And I was going to tell you guys a little bit about the specific company that I'm doing now, which is Bright.MD. But again, I'll pause for a second and see if you guys got any questions or comments. Boy, I must be rocking it today. All right. All right, we'll do the company. Bright.MD. We talked about some of the same problems. Primary care access. And I put those slides, I focused on that area in the early part of the presentation because I do think that it's really a pain point, and I think it's going to get a lot worse before it gets better, and it's part of what we do around Bright.MD. So think about the experience that patients have. You know, they have low acuity conditions that come up. They make up 60% of the visit volume that comes into primary care. Earaches and rashes and sore throats, coughs, colds, flus, seasonal allergies, UTIs, and it makes up 60% of the visit volume that comes into primary care. And that consumes a tremendous amount of time, and it makes up about 40% of primary care spend. And then they call up when they've got one of those conditions, because that's what they've been trained to do, and they call up their primary care provider, and they say, hey, I've got one of these conditions. Can you get me in to get seen? And then you guys saw that map. You guys remember the map of the United States with those big, big numbers on there about wait times? That's what they hear, which doesn't make them very happy. When you've got a kid with a cough that's keeping them up all night, or you've got an itchy, uncomfortable rash or a burning UTI, you want care yesterday, not 66 days from now. And so they get that message when they call their primary care provider's office, and that kind of doesn't make them very happy. So what we've done is we've actually built a platform that we license 2 delivery systems. And for me, I'm going to talk a little about my philosophy behind the business. There are other companies out there who are looking to kind of disrupt the healthcare delivery system and be delivery systems. They kind of want to siphon off these low acuity visits from existing primary care providers and take care of them virtually. You know, they hire docs and they're like, come over here because your doc can't take care of you quick enough, so come on over here and we'll take care of you faster, and you know, it'll cost you a little bit less. And we really don't want to do that. We really believe that care delivery is better with your primary care provider, with that continuity and with the relationship that you have. But we also think that it is better to work smarter than harder. You know, think about the agricultural revolution. You know, I mean, we get this explosion of population, and we need to feed more people. And you can either throw more farmers at it with picks and shovels, or you can build a tractor. Right? I mean, that's, and it's kind of the same thing. What we're doing right now is we've seen this explosion of demand for primary care services, and what do? Is we're going to train more providers. We're going to throw more bodies at it, and then we're going to whip them to go a little bit faster. And what we're trying to do instead is help them work smarter. So they can point their patients towards this online service that they staff, and the patients go on and they answer a set of branching logic, adaptive clinical questions. Really thorough. Think about kind of a virtual physician assistant of sorts, where we really can be incredibly thorough. We ask them all these questions and get a really complete interview from them, ask them preferences. We actually even bake in clinical logic where if you answer a set of questions in a way that makes you a higher risk patient, you know, you've got sore throat, but you've got a fever, and you've got, you have a hard time swallowing food, and you've had it for an extended period of time, well, maybe that's a peritonsillar abscess. We'd probably bring that in. Probably not still, but we escalate a pretty decent chunk of people, about maybe 10% of visits. We escalate through that process, you know, and that's just purely based on the algorithms and the logic that are baked into the tool. But assuming you make it through there, we bundle up all of those, all that information, and we present it to providers in a really easy-to-use format. So instead of spending 20 minutes. That's what it takes on average, about 15 to 20 minutes for a primary care provider to interview, evaluate, diagnose, prescribe, document, bill, do the whole shtick. That's what it takes, is about 20 minutes of primary care provider time. What we've done is we've taken all of that information and we've put it into a format that's incredibly easy for them to be able to use. We try to take out all of the waste We had one of our clients call us the ultimate lean for primary care. And you guys do leanness? Yeah. So, I mean, the idea is just, why? Ask that question, why? Why are we doing this way? Or, is it really the most efficient, effective way to be able to do it? And so that's what we've done. You can see, I'll point out a couple of quick features. Features matter less than the value that they create. But, we have diagnosis up there. We actually have, you can see that's a drop-down. You have a differential there that you can change it from. You've got treatment options. You've got patient education. We write the chart note for the providers because, especially around these low acuity conditions, those chart notes, they're algorithmic. They're predictable. And again, if there's clinicians out there who want to debate this, I'm totally open to talking about it. But we've heard a really fantastic response around this. I mean, the charting that happens now is not because it's what I need for clinical care. It's because it's what I need to do in order to get paid. And so we can help with that process and make it smoother and more streamlined and let providers focus on top of licensed practice. Free them up. So now instead of taking 15 to 20 minutes, it takes about 90 seconds to 2 minutes to be able to complete an exam, which means that providers can spend more time with those complex patients, those people, those diabetics who've got congestive heart failure and COPD and a foot ulcer, and they're going to wind up in the hospital if they don't get more care outpatient. But they're still getting fit in. Think about a provider's workday. You see an ingrown toenail, and you got a 20-minute slot of time to be able to take care of that. And then you see that diabetic with a foot ulcer and COPD and congestive heart failure, and then you got to fit them into a 20-minute slot. And that's really not the way that it ought to be. So what we're trying to do is say, okay, we've really created that process historically where we create schedule slots and we fit patients in regardless of whether that's where they ought to be or not. We're saying for these low acuity conditions, let's make those really simple to give you more time to be able to spend with those other folks, free up your time to practice again at top of license. I could talk about the economics around this as well. I don't know how much interest you guys have, but quick show of hands. I can skip through that stuff really fast, or I can dive into it. Who wants to hear more about kind of the value we end up? Okay, that was a decent number of hands. I won't do the other side of it. Okay, so if you think about that, the first thing that we do around this is we help drive down the cost per unit of care. Traditionally, healthcare delivery for these low acuity conditions, 99212, 99213 mix, they cost about $80 to deliver a unit of care. That's MGMA numbers. That's pretty well established. That doesn't mean that that's what every healthcare delivery system costs. And many large integrated healthcare delivery systems, in fact, they cost a lot more per unit of care to deliver it, and they're okay with that. They actually lose money on primary care because they're going to make money on filling hospital beds, and their primary care is their channel to be able to fill those hospital beds. And they're okay doing that. But on average, it costs $80. And they get reimbursed for those same 99212, 99213 mix at $85 a visit. So you're making, as an organization, $5 in margin for a 20-minute visit, which is not great, but it's okay. Now, that doesn't Medicare, Medicaid, that reimburses at like $46 per visit, $80 in cost. You guys can do the math. That's not necessarily a fantastic setting to be able to do that in. What we've done is we've taken all of the incremental drivers of cost in healthcare. We've taken real estate, support staff, physician time, and we've driven them all down by taking out some of that waste, which doesn't need to happen. And so the total cost per unit of care ends up being about $15 per visit, which is great. That's great for patients because we've driven down the cost, great for providers because now they actually can make more margin on those visits and they can actually get seen more quickly. And the nice thing is that payers like it too because they can reimburse not at $85 per visit, but e-visits are reimbursing at $40 to $65 per visit. So you've driven down total cost of care, so the system is actually costing less. Providers are making more money, which means they also can charge patients less and they can get patients seen more quickly. So that is our goal, is to drive that triple aim win. You improve outcomes, you improve experience, and you drive down cost. And that was really our motivation around that. But again, the other thing that we've done is what used to be 20 minutes of time is now 2 minutes of time. And that's really powerful. Much more valuable, actually, for everybody than what we've done on that per visit basis. And I'll show you really quickly on an annualized basis how we do this. So you hire a primary care provider as a delivery system. and you make about $70,000 per year annually now. So we went from a per-visit model to an annual model. Provider makes, for their organization, about $70,000 per year in margin. We're hearing these numbers, 22 patients a day are what providers are being now pushed to see. That's a lot of patients. But if you see 22 patients a day, saw that 60% of patients are eligible for this. We were talking about that earlier. We said, okay, we'll round down to about 11. 4 patients out of those 11 who are eligible actually use the service. They're making more margin here. But the nice thing also, though, is we're also, more importantly, those 4 visits that used to take 80 minutes, now they take 8, which means that you've got more capacity. And we saw the capacity crunch that we were struggling with earlier. So it's not like, it's not like you're just sitting there with an empty office. You've got a 30% shortfall in the ability to be able to meet patient needs. And that doesn't include things like what else we're asking providers to do, like panel management and coordination of care. That just assumes that every unit of care ends up being the same size as it used to be in the past. So we're backfilling now, and we're backfilling with patients who really need care. And then you've also got after-hours care and e-visits that are happening that aren't very efficient. And you've got the downstream revenue that you can make from your hospitals. But even more importantly, this is the part that I really like, is that we're making more capacity for patients in need. We're helping make sure that we can spend that time with diabetics and with complex patients, patients with psychosocial challenges, and patients with complex care needs. And the nice thing is that because of those same shifts that we're talking about, moving from fee-for-service into a value-based model, the last place you want to be spending your time and your money is on earaches and rashes and sore throats. You want to be spending your time taking care of those patients who really need to be in your office. And the neat thing is that in that model, you actually make money for doing it. If you coordinate that care and you keep those patients out of the hospital and you spend time not with the earaches but with the diabetics, then you can actually really extract even more value and even more importantly create more value through that process as well. So that's kind of the overview of Bright.MD. We've got a few minutes here, and I will put kind of a stop on my prattle up here and see what questions you guys have and how I can help out.
So we already know that Bay Area is very favorable for startups.
Oops.
And what kind of opportunities like incubators or seed funds are here in Portland?
Oh my gosh. There are now 14 incubators, 2 of which that are starting up right now in Portland. There are 14 incubators total for startups. That's a ton. And 2 of those 14 are actually healthcare IT specific. So there's a ton of resources that are out there to support this. Portland is a fantastic market for 2 reasons. One of them is that it's really put a lot of focus towards entrepreneurship, specifically around software development and engineering. But it's also really less expensive than the Bay. The technical term that people like to use for that is capital efficient. What that means is you can raise less money and do more for it. And you are seeing an increasing amount of money that is available, and everybody sees the same problem. The fact that we're spending 20% of GDP, that alone gets investors really interested. They say there's 2 things that an investor looks for in a company. One of them is the size of the pond, and the other one is the quality of the fishermen. When the spend, $4 trillion in spend, is a really, really big pond. And like I said, there's an incredibly target-rich environment in healthcare, and I think people are recognizing that. And so then the question is, how good of a fisherman can you convince people that you are? So, other resources. I would say we're actually uniquely positioned in Oregon specifically. Also, we have an incredibly progressive state government around healthcare legislation. We have a pretty competitive, arguably one of the most competitive healthcare environments in the country. And we have a ton of delivery systems. We got a ton of competing health plans. Not all markets can say that. So that really helps also fuel all that. We're leading the country in a lot of ways. There's a ton of talent here from a development standpoint, thanks to, in part, some of the work that you guys are doing. There's also a ton of informatics and EMR-specific technical talent that's here, which is relatively unique. So there's a ton. I could go on and list a bunch of reasons why I'm here and not there, besides the fact that Portland is way cooler than the Bay. Yeah. What else? Yeah.
I had a question. You mentioned that 60% of patients are eligible, meaning that they're low acuity. Mm-hmm. And so that would kind of infer that 60% of physicians are working below the top of their license.
Oh, much more than that.
Okay. So with this, with kind of the shift towards models that you're talking about, do you think this is also going to fuel a shift in the types of providers that are addressing these patients, maybe increase of more use of nurse practitioners, for example?
Yeah, no, I definitely think so. In fact, we, at this point, what we've seen from our clients, I'm biased, so I will not talk about my thoughts on it, but from what we've seen from our clients, the folks who we're working with, mid-level providers are the folks who should be doing a lot of this care. If we want to create the most value possible, you don't want to staff this. You're not staffing this with a cardiologist. Let's go to the other extreme. You're not going to get an orthopedic surgeon to sit down and do these. There's no reason for them to be doing that. The question is, how can you help people, give them the tools to be able to operate at the top of their particular license? And yes, so I think mid-level practice is a very important piece of it. It doesn't mean that we don't give them tools to help them work smarter. I think it's a combination of both of those. It's staffing changes, as well as operational changes, as well as the tools that we're using to support them. Does that answer your question? Okay. Yeah.
So I have a couple of questions. First is, how do you build your knowledge base, or how do you feed this algorithm you've developed?
Yeah. So we are, there is not a set of compiled clinical data or algorithms out there. So we have to build that. There's algorithms out there around things like diabetes and cancer care. Oddly enough, there weren't algorithms out there around earache. Now, that doesn't mean that there's not data out there, and peer-reviewed journal articles and best practices, and so what we've done is we've aggregated those. We have a clinical review process and a clinical review board. We also offer to all of our clinical partners, as we call our clients, our clinical partners, because we really do partner with them. We open that up and we let them look at those algorithms and give us feedback. We don't do custom algorithms. And I think that's actually a really important point. If you don't like the way we ask you a question, okay. Now, if you have an evidence-based reason, we don't think we know everything. That's actually another thing I think I should have mentioned, that listening piece. You got to listen with an open mind as an entrepreneur. I definitely don't know everything, not by any stretch of the imagination. So, we ask them, tell us. If we've missed something, let us know what we've missed and give us the information to support that claim, and we will bake that in and work towards building the very best algorithm for everybody. Does that answer your question?
Just a follow-up.
Yeah.
So we've seen this happen in the media nowadays, more than ever maybe. So what happens if your algorithm makes a mistake, or maybe a patient is diagnosed with a flu and had something else? Who's liable? Who's
we've actually baked in a bunch of safety net processes around that. The most important piece is we gather information, we organize the information, we present that information to providers, and we let them act on it in a really efficient way. But the providers are the people who make that decision, and we give them granular information so that they shouldn't trust us. In fact, when we go in and we talk with our clinical partners, I'm like, don't trust me. Please go in and look at these. You look at the questions and look at the answers that are available there. We will earn your trust by having the very best algorithms. And in fact, we hear consistently from providers in the 4 minutes of time that they've got to interview a patient, they don't have anywhere near the ability to be able to ask the 30 to 70 questions that we do. And through our, we're never tired, we never forgot our cup of coffee, we're never bored, we're never rushed. All those things that happen because we're human beings doesn't happen because it's a computer. And we have the person who is the most engaged and the most interested in getting high-quality health care to the patient involved in that process much more directly. And so we actually believe that by doing that, being really, really thorough up front and getting all that information, documenting it really thoroughly, and then providing it to providers in a very transparent process, but also a very easy to consume format, we can really help with that. The other thing that we do is we set a really low threshold for escalation. So like I said, if we have 1,000 patients come in for sore throat, one of them's got a peritonsillar abscess maybe, or something else that's serious like that. We escalate 100. And that's fine, because that's the neat thing. We're still treating 90% of the patients with faster care, lower cost care, and with higher outcomes, because we can be more thorough in our evaluation around that. And we improve the care for all the other people who now have more time to be able to get it. So that's another piece that we do. There's a bunch of pieces. And if you're interested in the specifics around how we do that with the product itself, I'd actually be happy to give you a little demo sometime as well. Other questions? Yeah.
So what are the different areas or fields you feel that in healthcare are ripe for disruption?
How long do we have? They all are. Yeah, no, they all are. There's an incredible amount of them. I think we're moving into a I heard somebody talk about this in the 3 phases of healthcare. We had the pre-EMR phase of healthcare, where you had to have 3 docs in the room, and one of them's transcribing, the other one's writing orders, and another one's asking the patient questions, interviewing. That did happen. I mean, there actually that happened not that long ago, like 50 years ago. That was less than 50 years ago that was happening. We had the EMR period where we're actually implementing these EMRs, and now we can actually do things like measure, look at quality, and look at utilization, and standardize some of that stuff. And then we've also got the post-EMR phase now, which is where you start. The EMR systems are, I believe, likely to act as databases, almost operating systems, if you think about it. But they're not going to be able to keep up with the kind of innovation that smaller companies are going to be able to do. Layering on top of that and being able to use that data. We do that with Bright.MD. We take in medications, allergies, problem list, labs. All those pieces are information that we can take, and we can process that and use that to help the providers rather than having them go look it up. How do we ease their way? How do we make things move a little bit more smoothly? I think there is always room to continue improving on quality and how do we measure that. But again, that definition around that is a really important one. I think, I really, from my perspective, the biggest pain points that we hear, taking that product mindset, what's the pain that people are feeling right now and how can we solve that better? The things that we hear are about that capacity and patient access and provider burnout and the inability to be able to shift from these fee-for-service business models into value-based models. Tools that can be built that do that, that help with any or all of those pieces, I would say are really, really high value right now. And I would say that they're, of all of the targets out there, those are the ones that are probably highest value. Does that help? Yeah, and like I said, long list. We could talk about the granular pieces a lot more if you'd like some other time.
Okay, well, thank you very much.
Yeah.
Maybe stick around for a few minutes if anyone has any questions.
Happy to. Yeah.